Welcome to our video on hormonal contraception and intrauterine devices. Let's get started. There are many different types of hormonal contraception, including oral contraceptive pills, a contraceptive patch, the NuvaRing, a depot shot, Nexplanon implant, and many IUDs, or intrauterine devices. So let's begin by discussing oral contraceptive pills. Oral contraceptive pills are highly effective oral medications designed to prevent pregnancy. Now, there are two general types. There's estrogen-progesterone pills, also known as a combination pill, and then there's progesterone-only pills, and those are called mini pills. And the exogenous estrogen within these pills, at least the combination pills, will inhibit FSH and thus suppress follicle maturation. Now, the exogenous progesterone, on the other hand, which is present in both the combined and mini pill, works in two key ways. First, it inhibits LH, which leads to suppression of ovulation. Second, it thickens cervical mucus, which creates a thicker barrier to sperm entry. And it thins the endometrial lining, which prevents implantation of a fertilized egg. Let's utilize this figure to illustrate the effects of exogenous estrogen and progesterone. And as mentioned just previously, the exogenous estrogen in the pill will inhibit the function of FSH. So as you can see here, it will deprive a developing follicle from stimulation, so it won't grow. But the exogenous progesterone will inhibit the function of LH, and it will prevent ovulation from taking place. So what this means is that both exogenous estrogen and progesterone will minimize a woman's chance of becoming pregnant, which is the whole point of these pills. Now here's an image showing a pack of oral contraceptive pills. Each pack contains 28 pills, and those need to be taken daily for maximum efficacy. That being said, some formulations of oral contraceptive pills may require women to take 3 weeks of hormone-containing pills, and then 1 week of placebo pills. And it all depends on the exact prescription. Unfortunately, that's outside the scope of step 2. In addition to preventing pregnancy, the combination pill also has several important therapeutic indications that are worth mentioning. Those include primary dysmenorrhea and ovulation, which can be seen in women with polycystic ovarian syndrome. These pills can also be indicated for anemia, and that makes sense. If they're losing a lot of blood during menstruation, then they can develop anemia, and these pills can help with that. You can also use it to reduce cancer risk, for example, endometrial cancer. You can also use it for acne or hirsutism, or even ovarian cysts. Now, in each of these cases, the combination pills lead to a reduction in the discomfort, if that's the issue, or pain, or other bothersome symptoms through various hormonal mechanisms. Beyond the therapeutic indications of combination pills, it's also important to know several of its adverse effects, almost all of which are largely attributed to estrogen. And realizing that, hopefully it makes sense why there's also a mini pill that just has progesterone and doesn't have estrogen. But what are these adverse effects of estrogen? Well, women on long-term estrogen therapy are at greater risk of developing hypertension and hypercoagulability, and that may dispose them to complications like stroke, myocardial infarction, DVT, or a PE. Prolonged estrogen therapy has also been associated with benign hepatic tumors, for example, hepatic adenoma, and increased risk for gallbladder disease, for example, cholelithiasis. Lastly, estrogen therapy has also been associated with an increased risk for cervical cancer, in part due to the fact that women on contraceptive pills are less consistent with using barriers like condoms to prevent against HPV. And you can understand the rationale. They think, okay, well, I'm going to prevent pregnancy because I'm on the pill. So a lot of them don't take those necessary steps to protect themselves from STIs. Unlike a combination pill, a progesterone-only pill doesn't contain any estrogen. For that reason, it has a more favorable side effect profile, which I alluded to earlier. That being said, it has a higher fail rate than the combination pill, mostly because it requires a more punctual schedule for maximum efficacy. In other words, this pill must be taken pretty much at the same time of day, every day, because a delay of a couple of hours would pretty much be considered a missed pill. And that can be tough. That's a lot to demand on the patient, but it's the reality. If you want to decrease the side effects, then you gotta be more diligent. Lastly, progesterone-only pills tend to worsen acne rather than improve it like the combination pills do. Now, there are several common reasons for discontinuation of oral contraceptive pills, regardless of whether it is a combination pill or a progesterone-only pill. One of the reasons is breakthrough bleeding, which means occasional menstrual spotting or unpredictable periods. Another reason is dyspepsia, as some women experience bloating or nausea while on oral contraceptive pills. And perhaps the greatest reason for discontinuation is a requirement to take the pill every single day around the same time. And that can be particularly bothersome for patients, especially in light of the fact that there are other methods of contraception and that really require a lot less hassle. Let's do a quick question. A 24-year-old female medical student presents to the clinic because her blood pressure was noted to be elevated during a clinical skills class. Her past medical history is unremarkable, and her only medication is a combination oral contraceptive pill. Today, her blood pressure is 140/90 and her BMI is 23. What is the next best step in management of this patient's hypertension? The next best step is to discontinue her combination oral contraceptive pill and consider an alternative method of contraception. This is because combination oral contraceptive pills are known to increase a woman's risk of developing hypertension, especially if used for a long period of time. So, whenever presented with a young, otherwise healthy female taking estrogen-containing contraceptives with no obvious reason to have an elevated blood pressure, then clinicians should strongly consider the possibility of secondary hypertension due to the contraceptive pills. So again, the next best step is for her to discontinue her estrogen-containing contraceptive pill. Next, let's discuss the contraceptive patch, as well as the NuvaRing depot shot and the Nexplanon implant. A contraceptive patch is a patch that continuously delivers estrogen and progesterone through the skin. And each patch lasts only a week, and it's commonly placed on either the upper arm, the back, the abdomen, or the buttock. Generally speaking, the patch is just as effective as oral contraceptive pills in preventing pregnancy. However, it is important to note that the patch is considered less effective in women who weigh over 90 kilograms, or 198 pounds. And because of that less effectiveness with that high weight, then that weight cutoff is actually a relative contraindication. Another important fact to know about the patch is that it is associated with a higher risk of venous thromboembolism than the estrogen-containing oral contraceptive pill, which is kind of strange because you would think that they're getting estrogen either way, and they are. But the reason that there's an increased risk with the patch is thought to be because of the increased exposure to estrogen because of the patch. So for whatever reason, the patient's getting more estrogen overall because of the patch. Now here's an image showing the typical appearance of a contraceptive patch. The general prescription pattern is to use one patch a week for 3 consecutive weeks, and then have 1 week without a patch to allow for a hormone-free period. The NuvaRing is a vaginal ring that continuously releases estrogen and progesterone into the bloodstream. You may have heard of a contraceptive diaphragm or a cervical cap. Well, those have fallen out of favor because of how inconvenient they are. The NuvaRing, however, is one size fits all and lasts up to a month. And the ring usually remains in place during intercourse. However, some patients may experience a foreign body sensation during intercourse if the ring remains in place. Now, fortunately, the ring can be removed for the purposes of intercourse, but if it is removed, it should be rinsed out with lukewarm water and replaced within 3 hours to avoid compromising its efficacy. Now lastly, the ring is just as effective as oral contraceptive pills in preventing pregnancy, but unlike the pills, it can lead to increased vaginal discharge. Here's an image showing the appearance of a NuvaRing. The general prescription pattern is to have the ring in place for 3 consecutive weeks and then remove it for a week to allow a hormone-free period. Now let's move on to the next type. The depot shot is essentially an intramuscular injection of progestin that is given to patients by a clinician once every 3 months. Now, each shot prevents pregnancy for up to 14 weeks, giving patients a little wiggle room in their scheduling their next shot. It's important to know that about half of women will experience amenorrhea after 1 year on the depot shot, and there actually may be a delay in return to ovulation following cessation of use. So you can kind of think of the depot shot as being long-lasting, but sometimes it lasts too long, even when the patient wants to have a return of their ovulation. Now, it's also important to know that the depot shot may lead to decreased bone mineral density after 2 years of use. And that's kind of interesting. The reason that this is thought to occur is because of decreased production of estrogen from the ovaries as a result of taking an exogenous progestin. Fortunately, that decreased bone mineral density idea is actually a reversible side effect once you discontinue the depot shot. Now lastly, weight gain is a common side effect associated with the depot shot. Now here's an image of the depot shot. Notably, it is referred to as the Depo-Provera shot, as can be seen on this label, and a medroxyprogesterone shot. But just remember that this shot contains progestin. A Nexplanon implant is a plastic rod placed under the skin by a clinician, commonly in the upper arm. It continuously releases progesterone into the bloodstream, and it's effective 24 hours following placement, and it lasts up to 3 years with no maintenance required. Now, a critical point to know about the implant is that it is the most effective method of reversible contraception. So I'll repeat this again. The Nexplanon implant is the most effective method of reversible contraception, and that's very important to know for exams. The main side effect of the implant is that it often causes irregular menstrual spotting, and the only hassle associated with it is that it needs to be removed by a clinician. And the fact that it does need to be removed by a clinician is fairly intuitive, considering it's implanted under the skin, and you don't expect or want your patient to dig around in their skin and do a little procedure on themselves like that. So here's an image of the Nexplanon implant. Now, as mentioned on the previous slide, this plastic rod is placed under the skin and can stay there for up to 3 years. Now, before we move on to discuss intrauterine devices, it's important to familiarize ourselves with the absolute contraindications to estrogen-containing contraceptives. And you think, why are we worried about the contraindications to estrogen specifically? Well, as we discussed earlier in the lecture, estrogen is usually the cause of most of the side effects associated with these contraceptives. Now, this table is organized from highest yield contraindications at the top to lower yield ones at the bottom. So perhaps the most frequently tested contraindications are hypertension, smoking 15 or more cigarettes per day, especially while age 35 or older. So remember that whole idea. So 15 cigarettes or more a day while 35 or older. Another contraindication is a migraine with aura or antiphospholipid syndrome. And what do all of these things have in common? The unifying reason for most of these is the increased risk of blood clots associated with estrogen-containing contraception. For that reason, it should make sense why a history of venous thromboembolism, such as DVT or PE, or a history of stroke, is an absolute contraindication to estrogen-containing contraceptives. Though it wouldn't hurt to know this table for exams, the focus should really be on the top 4 absolute contraindications. Now let's do a quick question. What is the most effective form of reversible contraception? So, as we mentioned before, the most effective form of reversible contraception is the Nexplanon implant. And that question should have been pretty easy, just because we just discussed this, but I wanted to bring this up because it's so important for you to remember. So now that we've covered the majority of hormonal contraceptive options, let's move on to intrauterine devices. And those tend to be the most popular form of reversible contraceptive, especially worldwide. Now, there are 2 main types of intrauterine devices. The levonorgestrel intrauterine devices, for example, the Mirena, or copper-based IUDs, such as the Paragard. Now, these devices require placement by a clinician, and they prevent pregnancy in 2 general ways. So first, they elicit a so-called sterile inflammatory response, and that actually kills the sperm that enters the uterus. That's especially true with the copper-based IUDs. And second, they impair tubal motility, which makes it substantially more difficult for sperm to reach and fertilize the ovum. Now, here's an image of an IUD, and it's inserted into the uterus. And note that T-shaped device with attached strings, and those strings are meant to extend just beyond the opening of the cervix, and that actually makes it easier for clinicians to locate the IUD and then remove it when they need to. Now let's discuss levonorgestrel IUDs in a little more detail. Levonorgestrel is essentially a form of progesterone, which is why, in addition to eliciting a sterile inflammatory response and impairing tubal motility, these IUDs also cause thickening of the cervical mucus and atrophy of the endometrium, which is just like the progesterone-containing oral contraceptive pills. So don't think of that as a local effect, because what's happening is the progesterone is going throughout the whole body, it's impacting LH release, and then these things are happening, the increased cervical mucus and endometrial atrophy. Now, generally speaking, this type of IUD is approved for use up to 5 years, although there are some situations in which they can last in a patient for up to 7 years. In addition to preventing pregnancy, levonorgestrel IUDs have several important non-contraceptive clinical indications, and that was true of the pills that we discussed earlier. In other words, there's more than just contraception that can warrant giving a patient an IUD. And here's the idea. These IUDs can be used to reduce the symptoms of dysmenorrhea and menorrhagia, and they may be indicated in postmenopausal women on estrogen therapy in order to prevent the effects of unopposed estrogen, such as endometrial hyperplasia or cancer. Unlike levonorgestrel-based IUDs, copper IUDs do not contain any hormones in them, so they elicit that sterile inflammatory response, and that's very local, and they impair tubal motility, just like the levonorgestrel IUD, but they also function by impairing sperm motility and capitation. But what is capitation? Well, this term capitation refers to the cellular process that must occur before the sperm is able to penetrate and fertilize an ovum. So the copper prevents that. Now, copper IUDs are in some ways more convenient than levonorgestrel IUDs because they are approved for use up to 10 years. So what's the downside? Well, the 2 main adverse effects of copper IUDs are menorrhagia and dysmenorrhea due to the irritation that this IUD may cause to the endometrial lining. And that's kind of an interesting contrast between the two types of IUDs. So again, levonorgestrel IUDs improve the symptoms of menorrhagia and dysmenorrhea, while copper IUDs can worsen them or even create them. Now, there are several notable complications associated with IUDs. Those include pelvic pain or cramps, device expulsion, perforation, and ectopic pregnancy. Now, this last complication may seem confusing. Aren't IUDs supposed to prevent pregnancy? Well, yes, they are. However, no form of contraception is 100% effective. And if a woman does get pregnant while using an IUD, the pregnancy is more likely to be ectopic. But fortunately for all of these complications, they're quite rare and almost never happen in real life. But they potentially can happen. Well, when can't you use IUDs? So these are some very important things to know, and we've shown them here on this table. So they're important to know for your patients in real life, and they're important for your exams. Now, the general contraindications include known or suspected pregnancy, or infection of the reproductive tract, such as pelvic inflammatory disease, or unexplained vaginal bleeding, or abnormal uterine anatomy, for example, large intrauterine fibroids, or gestational trophoblastic disease, like a hydatidiform mole, or endometrial cancer, or even cervical cancer. So all of those things are reasons to not give your patient an IUD of any kind. Now, when it comes to the specific types, levonorgestrel IUDs are further contraindicated in women with current breast cancer or liver disease. While copper IUDs, on the other hand, are contraindicated in patients with Wilson's disease or patients with a copper allergy. That's probably the most intuitive one. And then patients experiencing either active menorrhagia or active dysmenorrhea. Now, here's a summary table of the 6 primary methods of hormonal contraception alongside their typical use failure rate, duration of effect, and some other key points. Now, the term typical use failure rate basically means what percentage of women have become unintentionally pregnant while using this form of contraception. Hence, the lower the failure rate, the better the contraceptive option. Now, the failure rates are listed here for your reference and to make it clear how each hormonal option compares to one another, so you can compare and contrast them. However, it's not actually necessary to memorize all of these failure rates for the boards. It's just best to know which is most effective. Now, duration of effect refers to how long each contraceptive lasts. For example, each oral contraceptive pill lasts 1 day. Each patch lasts a week. Each NuvaRing lasts a month, and so on. And you may find it useful to review this table several times in preparation for your board exam or even your OB/GYN shelf exam. Now let's wrap up with a board-style question. A 23-year-old female presents to clinic to discuss birth control options. She says she is getting married soon and does not want to become pregnant for the first several years of her marriage. Past medical history is notable only for heavy periods, for which she is prescribed oral iron pills. The patient says she often forgets to take her iron supplements. She denies tobacco and alcohol use. Vital signs are unremarkable. Physical examination, including a full breast and pelvic exam, is unremarkable. Which of the following options should the clinician recommend for this patient? A. Copper IUD. B. Levonorgestrel IUD. C. Progesterone-only pill. D. Female condom. E. Cervical cap. Or F. Tubal ligation. Okay, so the correct answer here is B. Levonorgestrel IUD. So this is a case of a young woman asking about birth control options to prevent pregnancy for a few years. And notably, she has a history of heavy periods, and she forgets to take her iron supplements. So that all makes the levonorgestrel IUD the best option for her because, one, it's highly efficacious in preventing pregnancy, and it doesn't have the hassle of taking pills every day, which is something she says she has a hard time with, and it would likely improve her existing menorrhagia. So recall from this slide that levonorgestrel IUDs have 3 non-contraceptive clinical indications, and one of those, again, is menorrhagia. So in this patient, there are 2 reasons to give this to her. Okay, so that is why option B is correct. Now, option A, the copper IUD, is not ideal because a copper IUD would actually worsen her heavy periods. Now, option C, progesterone-only pill, is not correct because these pills require an extremely punctual schedule for maximum efficacy. And given that she forgets to take her iron supplements daily, then it makes sense that a progesterone-only pill would not be the best option. Now, option D and E are incorrect because both the female condom and the cervical cap are less effective than a levonorgestrel IUD in preventing pregnancy. And again, they're not used that often anymore. Now, lastly, option F, tubal ligation, is incorrect because this patient is very young and said nothing about her childbearing preferences. So in other words, we want reversible contraception for her. And a tubal ligation is not reversible. And that concludes this section.